Today we have with us Dr. Anil Dhal from Department of Orthopaedics, Maulana Azad Medical College, and we are dealing with common orthopedic problems in the geriatric population. So I would request Dr. Dhal to now start his session on what are the common problems which are encountered during the in the geriatric population.
Thank you, Dr. Ruchika. The common orthopedic geriatric problems can be classified into 4 basic categories. These are the traumatic, the degenerative, the infective, and the neoplastic. We will start with traumatic, and amongst the traumatic problems, the most common are the wrist fractures, the proximal femoral fractures, and the vertebral or the spine fractures. Looking at the plethora of these problems, I think any alert individual or a clinician will be able to appreciate that these are the areas which are most commonly affected in the osteoporotic spine, and that is why the wrist, the proximal femur, and the vertebral fractures are commonly seen in the elderly age group. As far as the wrist fractures are concerned, the commonest fracture which is seen is the Colles fracture. In local parlance, the Colles fracture or the distal radius fracture is a very, very common accompaniment of whenever there is a fall in the elderly age group. There is a dinner fork type of deformity which is seen at the wrist level. The wrist is swollen, and there should be no doubt in such a situation that the patient has a fracture of the distal radius. If you want to examine it or probe it further, try to put your index finger, one at the ulnar styloid and the other one at the radial styloid, and if you find that both these styloids are at either the same level or the radial styloid has gone proximally, then you are dealing with a distal radius fracture. To give you an idea, normally if you look at the wrist in your own hand and if you try to examine your colleague who has a normal wrist, you will find that the radial styloid is more distally placed than the ulnar styloid. So if this relationship gets reversed or disturbed, you are dealing with a Colles fracture, provided the patient gives you a history of a fall followed by a painful swelling in the wrist developing. The next common fracture which is seen in the elderly age group is the proximal femoral fracture, and amongst these proximal femoral fractures there are 2 distinct types, the one which is within the capsule and the other one which is outside the capsule of the hip joint, which is also known as the intertrochanteric fracture. Now the behavior of these 2 fractures is absolutely different, and that is why the need to classify them with the anatomical area of the capsule becomes essential. If you recall your anatomy, you would know that the capsule on the neck of the femur is attached anteriorly at the intertrochanteric line, and posteriorly this falls about a finger breadth short of this level on the neck of the femur. The blood supply to the head of the femur is precarious in the intracapsular part, and whenever there is an intracapsular fracture of the neck of the femur, the most important blood vessel, which is the lateral epiphyseal blood vessel, it gets torn, which means that the blood supply to the head of the femur is lost, and that makes this fracture prone to creating avascular necrosis of the head of the femur, as well as it makes it difficult for the fracture to unite because of the loss of blood supply in the proximal fragment. The other fracture commonly seen is the intertrochanteric fracture, also known as the extracapsular fracture. Interestingly, this area is richly supplied with blood, and therefore there is no difficulty in healing of the fracture or union of the fracture. But the commonest complication which is encountered here is a malunion in the form of a deformity which is known as coxa vara, meaning thereby that the neck shaft angle gets diminished. Again, recalling anatomy, the normal neck shaft angle is 125 degrees to 130 degrees in the adult, an average 127 degrees. Now, if this angle approaches 90 degrees, the deformity is known as coxa vara, which is commonly seen when intertrochanteric fractures are neglected in the elderly age group and they unite on their own. To give you an idea of what these fractures look like, again we should move to the monitor, and you would be able to see I'm pointing my cursor or the pointer to the fractured area. This is an intracapsular fracture of the neck of the femur, and this in the geriatric age group, as Dr. Ruchika was emphasizing that we need to talk about the examination of the patient also. If such a patient with an intracapsular fracture neck of the femur presents, he would give you a history that after the fall the patient has not been able to walk. He has not been able to walk or weight bear on the affected hip, and he had to be carried from the site of accident, put on a trolley or put in the car, and he has been brought to the hospital or the clinic by someone. If you examine,
is this type of fracture more common or is the extracapsular one more common?
I think in the elderly age group both are equally common, because we must realize it is the bone proximal femur which is very much prone to osteoporosis, and which part would fracture. It depends on the part on which the patient has stumbled and fallen. If the patient falls directly on the trochanter due to the stumble sideways, then the trochanteric fracture results. On the other hand, if he slips in the bathroom or if there is a rotational strain which is imparted onto the neck of the femur, then the intracapsular fracture would result. Since you have asked this question, it is very important that human biomechanics, which has been studied, to give you an idea how basic sciences can help in deciphering which fracture would occur in the elderly age group. It is very interesting, as the age advances, the gait of the patient also changes, and you must have seen the resilient or the elastic or the exuberant gait of a young person, which has sort of a springiness in every step. It slowly dwindles into a mere shuffle at the age of 80 years or so. And it has been seen that beyond 70 years, when this shuffling gait starts coming in, it makes the patient more prone to fall on the side. Whereas a young individual or a younger individual, maybe 50 years, 60 years, he tends to fall in front because his gait is more brisk. So this makes trochanteric fracture more common as the age advances, maybe 70, 80 years later on.
Is there any sex difference also among the male and female in the type of fractures?
Females generally, because of the postmenopausal osteoporosis coming in earlier, they are more prone to proximal femoral fractures than the elderly male. But by and large, senile osteoporosis starts setting in after 70 years in the males also. So maybe after 70 years of age, the incidence may be equalizing. But below 70 years, females are more prone to proximal femoral fractures. Now, this particular patient, if you examine him, you will find the most glaring fact is that the limb, affected limb, is lying in external rotation. And there is shortening, there is obvious shortening. If you compare the levels of the medial malleolus on both the sides, the affected limb medial malleolus would be proximally placed in comparison to the normal side. The other part in the examination which is most relevant for this sort of a history, that there was a stumble and the patient was unable to walk, and now the limb is lying in external rotation, just by asking this patient to actively try and lift up his leg. We call this as the active straight leg raising test. If the patient is not able to perform this, or if you lift it up passively and he is not able to sustain it, he is not able to hold it in that raised position against gravity, this is evidence enough that this patient has either an intracapsular fracture of the neck of the femur or an intertrochanteric fracture. Because clinically, though it is possible, if a very keen observer or an experienced orthopedic surgeon is examining the patient, he may be able to tell you whether it is an intertrochanteric or an extracapsular, because the extent of external rotation is much more in the trochanteric fracture, because the capsule offers some resistance to external rotation. However, it is best left to the plain radiological examination, get an X-ray done, and it will give you the final clue whether this patient is suffering from an intracapsular fracture or an extracapsular fracture. Because as I said, the treatment in both is absolutely diametrically apart. Before we embark upon further discussion on the proximal femoral fracture, I think we need to visualize what a trochanteric fracture looks like. So this is the intertrochanteric fracture. You can see this is the femoral
this is
neck.
Which view? I think you can just.
This is bordering on an oblique view. This is not a lateral view. This is not a dead AP view also. This is an oblique view. But classically, if you have a good AP view, you will be able to visualize the intertrochanteric fracture. This is the lesser trochanter area and this is the greater trochanter area. So this is the fracture line extending from the greater trochanter to the lesser trochanter, and that is why it is known as the intertrochanteric fracture.
It's a very glaring fracture, I think.
Yeah, and since we were talking about the management is different, as far as the intracapsular fracture in the elderly age group is concerned, the treatment of choice is hemiarthroplasty, meaning thereby that you remove the head of the femur, excise it and dispense with it, and you replace this head of the femur with an artificial head which comes in various types of prosthesis. The commonest prosthesis which has withstood the test of time is known as the Austin-Moore prosthesis, which all of you must visualize when you go to the orthopedics department. Tell your counselors or guides to show you the Austin-Moore prosthesis. You may have to visit the operation theatre for this. You can also visualize the surgery or be there while it is being done and see for yourself how the head of the femur is removed, and the biological head is being removed here and an artificial metallic head is being inserted. The more recent designs are the bipolar hips, which also can be visualized while you are in the orthopedic department. As far as the intertrochanteric fracture is concerned, we know that the blood supply is good, union is not a problem, we only need to maintain the neck shaft angle, and this in the elderly age group is now being standardized, or it is the procedure which is performed is a surgical procedure. Why surgery? We will soon come to it. The implant which is gold standard for fixing these fractures is known as the dynamic hip screw assembly, or the abbreviation is DHS. So many times you may be coming across prescriptions saying intertrochanteric fracture fixed with DHS. So this is dynamic hip screw fixation. Why should we operate? On one hand, we are talking about the various comorbidities which the elderly age group patients have. They are diabetic, they are hypertensive, they are having very little reserve function in the body, and we all know that they are not very good candidates for anesthesia and surgery. But in spite of that, the surgical option is the preferred one. It is solely dependent on the fact that prolonged recumbency in bed invites complications like bed sores, deep vein thrombosis, hypostatic pneumonia, and psychological complications like severe depression may set in. So to avoid these complications, if you fix this fracture peroperatively and make the patient ambulatory, within the first week or so, the patient gains tremendous confidence and he would also be psychologically much better off. The hazards of recumbency, you all know, they are life-threatening. So it is safer to opt for an operative fixation, and with the advancements in medical management of these problems as well as in advancements in anesthesia techniques, patients nearing 100 years of age can also be operated upon for trochanteric fractures, and they can have useful quality of life in whatever period is left in their lifespan.
I think I would like to interrupt you here, Dr. Dhal, and just stress on one point while we are going further on, and that is that you must keep the purpose of this course in mind while you are going through your clinical posting and while you are going through your material. Because as Dr. Dhal is telling you about the examination, the management, we must be clear that our purpose is how we should be able to take the history, how should we be able to examine, and then decide on the management. Most of us are not going to manage the patients unless we are in a big hospital. Most of us will be dealing with the patients as a family physician. So we should know, seeing not only the condition of the patient, seeing the social problems that the patient and the social environment he is living in and his finances, we should be able to advise him what kind of management is required for this treatment. Second, we should also know at what stage that the elderly must be referred. The purpose of this course is that we should be able to identify, for example, if we take the specific case, what is the type of fracture. Our main purpose is that we should be able to identify what is the type of fracture, so that then we are able to refer the patients. Unnecessary referrals to the hospitals should also be avoided, and at the same time patients who require the proper and emergency management should also be picked up and referred at the right time to the right place. Because as we know that referring an elderly to one hospital which may not be equipped to deal with the problems of that particular patient is a waste of lot of energy, time for that particular patient. We may refer an adult to a particular hospital, he may be referred from there to another place. That will not be such a problem. But then if we refer an elderly at the wrong time to a wrong place, then we may be losing that elderly's management forever. He may never visit another hospital another time. So this is one thing we must keep in mind. This is why this course is very important, so that we are able to deal with the people and decide whom to refer and when to refer and where to refer. That I think is very important.
I think Dr. Ruchika has brought out a very important point here. And more and more realization on this fact is coming up. Even within the specialty, a particular orthopedic surgeon, single orthopedic surgeon today cannot tackle all the super specialities which are emerging. Like everybody cannot be a joint replacement surgeon, everybody cannot be a peripheral nerve surgeon, everybody cannot be a sort of an arthroscopist. So the purpose of orthopedic training or postgraduate training in geriatric medicine, they are identical. If you cannot tackle the problem yourself, you should be able to refer the patient to a proper place. The purpose here is not that you start managing the patient yourself, but the purpose is that you realize this is the problem, you have a fair knowledge of what he requires and who would be the best person or the best center where this management can be done. And I agree with Dr. Ruchika that all this needs to be at the back of the mind. Please do not think that we are being taught about something which we are not going to operate upon this patient. So let the operative part be decided by the orthopedic surgeon.
Yeah, that is why when you see the program which has been written, with this thing in background we have written it. So we have not given too much in details about everything. We like to equip you with basic knowledge, basic principles, and of course you are welcome to have further readings. You may be an MD in orthopedics, you may like to take up extra things in your environment, but for a basic geriatrician that we are aiming is this. Now maybe we can start on the degenerative problems that may be faced by the elderly population.
Yes, apart from the fall, which is quite common in the geriatric population, the other common cause of pain is the degenerative disease, and I have purposely concentrated on the knee joint to give you an example of degenerative disease, which is commonly known as osteoarthritis. The reason being that the knee joint is a very, very important weight bearing joint. To give you a similar counter example, the elbow in the upper extremity has no weight bearing function, and it is very rare to find an elderly person complaining of pain in the elbow which is due to degenerative disease. There may be other reasons like tennis elbow creating pain in the elbow, but degenerative disease or osteoarthritis of the elbow is practically unknown. So this disease usually occurs in the major weight bearing joints of the body, and in the Indian population peculiarly, osteoarthritis of the hip is rare. On the other hand, osteoarthritis of the knee is very common. Probably it has got something to do with our habits, peculiar habits, like defecating in the squatting position and sitting cross-legged for our prayer position, or for our majority of the rural population sits in the cross-legged position while having their food, which these two positions probably put a lot of strain on the human knee.
I think even in the rural areas, working in the kitchen also, most of the women, they are squatting and mopping of the floor. I think everything requires bending of the knees.
So this position puts a lot of strain on the knee joint, and that is why probably osteoarthritis of the knee is more common in our elderly population than in the West.
Dr. Dal, one question is coming to my mind. I would just interrupt you to ask. Like most of the elderly patients that we encounter, they will come, they may not come up with this problem of joint pains many a times. And if you ask them, they will say, "Haan, budhapa hai, dard to hoga hi." Now, should we consider this osteoarthritis as a normal process of aging? And if yes, starting from what age? Or should we consider it pathological?
I think there is no harm if an old person says that I am growing old and a little bit of aches and pains are bound to be there. He is very right, because we must realize that every machine which is wearing out will start having some problems, and the wisdom or the beauty lies in the fact that if one can get adjusted to these minor aches and pains, as long as they are minor, but one should start taking care of these problems at an early date, so that these problems do not become major in the near future, because there is no substitute for the biological knee or the biological hip. It is only in extreme conditions or extremely worn out joints that we would like to go in for the total joint replacement option. Though the option is there, but it is in no way comparable to the biological knee.
What preventive measures you feel should be
Yes,
told to the...
we would like to make our students aware of what they can advise the society and the population coming to them, the geriatric population, especially the geriatric population, which is now just stepping into the door of geriatric age group. I think in the early 60s or in the late 50s, if the patient, because these patients do start having pain at an early age group, more so the population now, because we are getting used to the comforts. We have started avoiding walking to our place of work. There is no real exercise. There is no time for exercise for the majority of younger people. So osteoarthritic problems are coming in at a younger age group. Why this is occurring? Because we must remember that every time a ball bearing moves, there is lubrication going on. And similarly, every time a joint or a synovial joint moves, which the knee joint is a synovial joint, every time it moves, it produces a new film of synovial fluid onto the articular cartilage. And this is very important not only for the lubrication of the joint, but also for the nourishment of the articular cartilage. So if these joints are not being moved frequently, then the nourishment of the articular cartilage is suboptimal. And this starts leading to fibrillar changes in the articular cartilage, something which is known as chondrolysis. And this ultimately results in degenerative disease of the knee, which we call osteoarthritis. So my point is that exercise should be emphasized upon. The other thing which needs to be emphasized upon is control of weight. As the person is growing older, I think we need to emphasize that this is the time to shed weight. Do not carry extra weight into your geriatric age group. So warning the patient that now you have started having degenerative disease. Maybe it is the spine, maybe it is the knee, maybe it is the shoulder. This is the time when the patient should start aiming at an optimum weight for his height. And again, this is a vicious cycle. If he does exercise, his weight remains under control. If he does not exercise, his weight goes on increasing. And additional load on a degenerated joint, it is common sense, it is going to create more and more degeneration and faster degeneration. On the other hand, if you have a degenerated joint and the patient sheds 20 kilograms of weight, I think he will start feeling much better. His joint, the same joint which is degenerated, would last him a good 10 years more than had he not checked his weight. So this patient, we can predict, would require, an overweight patient would require a drastic procedure like joint replacement surgery much earlier than a lean and thin individual. This is how we talk about preventive geriatric orthopedic medicine. For cardiac conditions like the coronary artery disease, exercise is aerobic exercise, and different forms of exercise are being recommended so that neovascularization of the myocardium is facilitated. But nevertheless, depending on the exercise tolerance of the patient and taking the inputs of the treating physician or the cardiologist, an exercise program can be recommended to this particular patient. Like, to give you an example, for the knee joint, we consider cycling as a very good exercise. And cycling also probably promotes cardiovascular reconditioning. But if the cardiologist feels that he should not be cycling, then simpler or less strenuous exercises like sandbag exercises can be instituted. You can ask the patient to put a 1 kilogram or 2 kilogram sandbag on his ankle. He can sit on a chair and he can actively extend and flex his knee. It's a very, very light exercise, and I'm sure any patient who has a cardiac disease can do it.
I think
just by
even
sitting
walking is one thing which we can safely tell all the patients.
Yes, walking would help him reduce the weight, but it would not strengthen his quadriceps muscles, and that is quadriceps strengthening exercises are what are required.
We have two questions. One is what is the role of antioxidants in the degenerative changes? Because nowadays there is lot of media on the antioxidants.
Well, all these are controversial. You see, long-term studies and controlled trials are not available, and no two patients are the same. So, scientifically, I think it would not be wise to recommend this as an though it is, all these are being propagated as anti-aging agents. But how much of anti-aging effect they have on the articular cartilage? You see, it's a very simple, thought-provoking question. Why does the articular cartilage in the upper extremity is not aging and the lower extremity is aging? Probably it's got more to do than with the cyclic loading, rather than the antioxidant phenomenon or anti-aging phenomenon. So it is open to question whether antioxidant therapy would be beneficial.
The second question we have, that if in a geriatric patient we suspect that he's had a hip fracture and we want to refer him, then in what position should such a patient be referred?
I think it's a very, very relevant question. Basically, we know that since a geriatric patient, if he has an intracapsular fracture, it really does not matter whether we are inflicting further damage to the blood supply. In the younger individual, it does matter. It matters a lot. But since we are doing a head sacrificing surgery for intracapsular, that part does not matter. But at the same time, so that the patient is comfortable during transportation, he is pain-free or relatively pain-free, he needs to be put in a splint. And the most prevalent or the most accepted splint for this type of a fracture is the Thomas's splint, which is easily available in every orthopedic department. On the other hand, if in your small little practice or private practice or in a place where you are not having an orthopedic surgeon and this sort of a specialized splint is not available, you can just use any splint material like a log of wood,
hardboard or something.
A hardboard, or if nothing is available, just strap the affected limb to the normal limb, just like a mermaid. Just put bandage across. So the normal limb acts as a splint for the affected limb. And you can transport the patient to the definitive care center with this splint.
Should we take up the infective disorders?
Yes, we can. Just to show them the X-ray of the degenerative osteoarthritis knee. If you look at the X-ray of the knee, this one needs to know that when you advise an X-ray for osteoarthritic knees, the best way to do it is the patient should be in the standing or the weight bearing position, and antero-posterior X-rays should be taken. There is a diminution in the joint space in the medial compartment. This is the medial compartment, and the joint space is reduced in comparison to the joint space in the lateral compartment. This is the tibiofemoral compartment. So this reduction in joint space is by virtue of the fact that the articular cartilage has degenerated and it is now resulting in a painful knee.
We have a question asked that why are oral calcium preparations used for normal degenerative conditions or other conditions in orthopedics?
Well, I personally do not use calcium at all for promoting fracture healing, because it has got no rationale at all. And I am really surprised at any qualified orthopedic surgeon advising calcium. However, I can understand if a patient at hand is an osteoporotic individual and there is some problem about the calcium intake. Calcium supplementation in elderly females is quite in order, but one should not go away with the idea that this is being given by the surgeon for promoting fracture healing.
And what about the degenerative conditions?
Even in degenerative condition, the calcium probably has no role. It is only in osteoporosis. If you are trying to halt or trying to retard the process of osteoporosis, because whatever bone loss has already occurred cannot be regained. We all know that. It is only that we can retard this with the newer therapies which are available, like bisphosphonates, alendronate.
But the supplement of calcium which is recommended for women, especially after the menopause, maybe it is coinciding with the geriatric patient visiting a doctor, and probably in addition to the treatment which is offered, the calcium may be being prescribed.
Yes, that is very much in order. But
so specifically, I think for the treatment of the condition that the patient goes to a doctor, he doesn't prescribe the calcium, but I think he prescribes it for the osteoporosis which may occur because of the postmenopausal state of the patient.
Yes, and right in the beginning we have already spoken of treating the patient as a whole.
Yeah.
Do not just treat the fracture. You have a look at your patient. If you feel that there is gross osteoporosis, the patient has not taken any therapy, he is totally oblivious of the fact that his bone mass is going down. There is no harm in advising him some therapy which would take care of this problem. Or if you find that there is an elderly age group lady who is not having adequate calcium intake in the form of milk and milk products, she has very little exposure to the sunlight, there is no harm in giving her calcium supplementation. And it is...
but you do not recommend it for as a blanket for all the...
I don't think so. I don't think so that it should be recommended in all patients, and especially patients who have fractures, and to advocate it as a form of enhancement therapy for fracture healing, it is totally out of order. I have a slide which shows the osteoarthritic knee in the advanced stages, which has been subjected to a total joint replacement procedure. This is the femoral part of the prosthesis, and this is the tibial part of the prosthesis. Both AP and lateral views have been taken. And as far as the infective process is concerned, it needs to be realized that old age itself is also an immune deficient stage. And coupled with concomitant diabetes, I think these patients become more prone to infections. And as far as orthopedic surgery is concerned, osteoarticular tuberculosis is very common. Apart from this, elderly age group is very much prone to the neoplastic processes. Multiple myeloma is a very, very common condition amongst neoplasms. And here we have an X-ray showing multiple vertebral involvement. And if you get the Bence-Jones proteins, electrophoresis of this patient, and a bone marrow biopsy, you may hit upon the diagnosis. And last but not the least, unknown primary can lead to secondary deposits, and proximal femoral is a favored site, proximal femur, proximal humerus, and this can lead to an impending pathological fracture which has been stabilized by an internal fixation device, and the patient can have a good quality ambulation while the disease is progressing, because it is stage 4 disease and we cannot really help eradicate the disease.
I think it was a very, very exhaustive, and we covered all the topics which need to be covered for the common orthopedic problem, and I would really like to thank Dr. Dhal for giving an excellent presentation, and it was very nice of him to have brought out the X-rays so that we could get a better idea of all the disorders. Thank you so much.